Hey everyone, Alvin here. Let's talk about something that can be incredibly frightening for any expectant parent. Bleeding during pregnancy. While it doesn't always mean something is wrong, there's one specific cause that you absolutely need to know about. Imagine this. You're well into your second or third trimester, everything seems fine, and then suddenly, you experience painless, bright red bleeding. This isn't just a minor scare. It could be a sign of a serious condition called placenta previa. In this video, we're going to dive deep into what placenta previa is, why it happens, who is at risk, how it's diagnosed, and most importantly, what you need to do to ensure the safety of both you and your baby. This is crucial information, so stick with me. So, what exactly is placenta previa? Let's start with the basics. The placenta is an amazing organ that develops inside your uterus during pregnancy. Its main job is to provide oxygen and nutrients to your growing baby and to remove waste products. Normally, the placenta attaches to the top or side of the uterine wall, well away from the cervix. The cervix is the opening to the uterus, located at the bottom, which needs to open up for a vaginal delivery. Now, in a case of placenta previa, the placenta implants itself in the lower part of the uterus, partially or completely covering the cervix. Think of it like this. If the cervix is the baby's exit door, placenta previa is like having a big, soft blanket blocking that doorway. This position is problematic because as the baby grows and the uterus expands, especially in the later stages of pregnancy, the placenta can be disrupted, leading to bleeding. There are actually a few different classifications of placenta previa, and your doctor will specify which type you have. The first is complete previa. This is the most serious type, where the placenta entirely covers the cervical opening. You can imagine why this makes a vaginal delivery impossible. The baby simply can't get out without causing severe bleeding. Then there's partial previa, where the placenta covers only part of the cervix. Finally, we have marginal previa. In this case, the placenta is right at the edge of the cervix, but doesn't cover it. There's also a related term you might hear, low-lying placenta. This is when the placenta is located in the lower uterine segment, close to the cervix but not right up against it, usually within 2 centimeters. Sometimes, a low-lying placenta diagnosed early in pregnancy will resolve on its own as the uterus grows and pulls the placenta upwards and away from the cervix. This is called placental migration. However, a true placenta previa, especially a complete one, is less likely to move out of the way. Now, let's talk about the biggest red flag, the symptoms. The classic telltale sign of placenta previa is sudden, painless, bright red vaginal bleeding. The color is important. Bright red blood indicates fresh bleeding, as opposed to older, darker brown blood. This bleeding often occurs without any warning and is unusually associated with the contractions or pain you'd expect with labor. It typically happens in the late second, or more commonly, the third trimester. Why then? Because this is when the lower part of the uterus begins to stretch and thin out in preparation for labor. This stretching can cause the part of the placenta attached over the cervix to tear away slightly from the uterine wall, which ruptures blood vessels and causes bleeding. While it's often described as painless, some women might experience mild cramping or contractions along with or after the bleeding starts. The amount of bleeding can vary widely, from light spotting to a heavy, life-threatening hemorrhage. It can also stop and start again without warning days or even weeks later. So, who is more likely to develop placenta previa? While it can happen in any pregnancy, there are several known risk factors. A big one is having had a previous cesarean section. The scar tissue from a C-section on the uterine wall can be an attractive spot for the placenta to implant. The more C-sections you've had, the higher your risk. Another factor is having had placenta previa in a previous pregnancy. If you've had it once, your chances of having it again are higher. Other risk factors include being pregnant with multiples like twins or triplets, because there's more placental tissue, and it has to find more space to implant. Your age also plays a role. Women over 35 are at a slightly higher risk. Smoking or using certain substances can also increase the risk because it can affect the blood supply to the uterus and influence where the placenta implants. Lastly, having had other uterine surgeries, like AD&C or fibroid removal, can also create scar tissue that increases the risk. If your doctor suspects placenta previa, perhaps because of bleeding or just as part of a routine check, how is it diagnosed? The good news is that diagnosis is usually very straightforward and non-invasive. The primary tool is an ultrasound. Most cases are actually first identified during a routine mid-pregnancy anatomy scan, which is usually done around 20 weeks. The sonographer will check the baby's development and also look at the position of the placenta. An initial transabdominal ultrasound, where the probe is moved over your belly, can often spot a low-lying placenta. However, to get a definitive diagnosis and see exactly where the placenta is in relation to the cervix, a transvaginal ultrasound is the gold standard. I know that might sound a bit intimidating, but it's a very safe procedure. A slim, wand-like probe is gently inserted into the vagina. It doesn't go all the way to the cervix, and it's done very carefully. This method provides a much clearer, more accurate picture of the lower uterus and cervix. allowing your doctor to see precisely how much of the cervix is covered, if any. Once you have a confirmed diagnosis of placenta previa, your pregnancy management will change significantly. The number one priority becomes preventing bleeding and keeping both you and the baby safe. The first and most important instruction you'll likely receive is to go on pelvic rest. This is a strict rule with no exceptions. It means nothing should be inserted into the vagina, no sexual intercourse, no tampons, and no douching. It also means no vaginal exams by your healthcare provider, unless absolutely necessary in a controlled hospital setting. Why? Because anything that stimulates the cervix or the surrounding area could irritate the placenta and trigger a bleed. In addition to pelvic rest, you'll almost certainly be placed on activity restrictions. This can range from simply avoiding strenuous exercise and heavy lifting to, in more severe cases, or if you've had bleeding episodes, strict bed rest. The goal is to minimize any physical strain or pressure on your uterus and cervix. Your doctor will tailor these recommendations based on your specific situation, the type of previa you have, and whether you've had any bleeding. So, what happens as you get closer to your due date? This is where the plan for delivery becomes critical. For almost all cases of complete or partial placenta previa, a vaginal delivery is not a safe option. Attempting to deliver vaginally when the placenta is blocking the exit would be catastrophic. As the cervix dilates, it would cause the placenta to tear away from the uterine wall, leading to a massive life-threatening hemorrhage for the mother and cutting off the baby's oxygen and blood supply. Therefore, the standard and safest method of delivery for placenta previa is a scheduled cesarean section. This allows the baby to be delivered through an incision in the abdomen and uterus, completely bypassing the cervix and the placenta. The timing of the C-section is a careful balancing act. Doctors want to let the baby mature as much as possible, but they also want to avoid the onset of natural labor, which could trigger contractions and bleeding. Generally, a planned C-section for placenta previa is scheduled around 36 to 37 weeks of gestation. This is considered early term, a point where the baby's lungs are typically mature enough, but it's early enough to reduce the risk of you going into labor spontaneously. In some cases, you might be given steroid injections beforehand to help speed up the development of your baby's lungs, just in case an even earlier delivery becomes necessary. Of course, this plan can change. If you experience significant bleeding at any point that can't be controlled, or if either you or the baby show signs of distress, an emergency C-section will be performed immediately, regardless of how far along you are. The key takeaway from all of this is incredibly important. If you are pregnant and you experience any vaginal bleeding, especially painless, bright red bleeding in the second half of your pregnancy, you must take it seriously. Do not wait to see if it stops. Do not assume it's nothing. You need to call your doctor or midwife immediately or go directly to the hospital's labor and delivery unit for evaluation. Don't try to diagnose yourself. Let the medical professionals figure out what's going on. It's always better to be safe and get checked out. When you get to the hospital, they will monitor you and the baby closely, perform an ultrasound to check the placenta's location, and determine the best course of action. For many women with placenta previa who follow their doctor's advice and have a planned C-section, the outcome is excellent, resulting in a healthy baby and a healthy mom. The key is careful monitoring and proactive management. Save this video and share it with other expectant parents. It's a vital part of your prenatal safety knowledge. Thanks for watching, and be sure to follow for more essential pregnancy tips.